So this is a part of the series of cancer care webinars, and I will be the moderator for Dr. Linda Watson, who is our presenter this evening. And our topic this evening is the follow-up and transition of care for cancer patients at the end of treatment. So at this point in time, I'd like to introduce Dr. Linda Watson. I've known Linda for a number of years. I can't remember how many exactly.
Quite a few.
But quite a few. I listened to presentations at Provincial Advisory Council for Cancer, of which I'm the vice chair. I have been honored to hear presentations on a variety of things that she's been involved in, including work that led up to this particular webinar, i.e. the Building Bridges and Building Capacities program. I worked on that as part of the research study, and also screening for distress. So Linda has been a very vital part of my life in cancer care. She, in her past life, was an oncology nurse in the Calgary area for over 25 years. She's held a variety of nursing and interdisciplinary leadership roles within the Alberta Cancer Control System, and she's currently the provincial lead for person-centered care integration within the provincial practices portfolio. She is passionate, as you will find, about the benefits of enhancing patient-centeredness for cancer care in our current system, and over the past several years has worked to develop a variety of processes that can be used both in our offices as family docs, but also within the broader cancer system. She has been involved in developing programs as well that enhance clinical engagement and tailored interventions at the point of care. That includes us, not just hospital-based care. Her presentation today will focus on her recent work done to improve transitions to the primary care post-treatment.
Excellent. Excellent. Thanks, Margaret. I'm so excited to be here today. Yeah, we will start the presentation. I can hear echo. Is that normal? It's probably that computer. All right, so I have no disclosures. This project was funded by the Alberta Cancer Foundation, and I am an employee of the Cancer Control Alberta in AIHS. There's also a part at the end of this in-service or this webinar where I will be referring to a program that has been designed for family medicine and oncology postgraduate training called Moving Forward After Cancer, and it's an e-learning suite, and it's been developed by Cancer Care Manitoba, BC Cancer Agency, Cancer Care Ontario with a grant from the Canadian Partnership Against Cancer. And it's a free web-based learning modules that are hosted by the University of Manitoba. And so I will give you the links, and we'll be watching one video from that program. We can talk more about that at the end of this session. It might be very useful for you as more content than I'll be able to cover today in our discussion. For those of you that have not heard of the Canadian Partnership Against Cancer, that is a federally funded organization that has been charged with moving forward on the Canadian strategy for cancer control. So the Canadian Partnership Against Cancer has been around since 2007 and has really been instrumental in moving cancer control strategies forward across Canada. So this project that I'm going to talk about today and was really developed to meet this overarching goal, which is to guide the evolution of our healthcare system and facilitate integration of systems so that Albertans finishing cancer treatments receive excellent post-treatment follow-up care in the survivorship phase of their cancer journey, regardless of where that care is provided. And that's really important because we know that cancer is actually 200 different diseases and a variety of different requirements for follow-up care. And so essentially, our goal is to ensure that whether that care is provided in cancer control facilities or in the family physician's office, that everybody has access to the best evidence to inform our practice, including the patients. So importantly to understand, the cancer care continuum really begins and ends within primary care. And so obviously cancer care is very focused on the developing of systems that focus on the treatment of cancer, whether that's surgery, radiation, or chemotherapy, or biotherapy. but we do not work in isolation from the larger system. So our patients, prevention for cancer, screening, and most of the diagnostic phases occur in primary care, as you well know. And then when we get to the other side of the continuum, when we're looking at after treatment, we have end-of-life care and survivorship phase, which are both often shared care or primarily looked after in the realm of primary care. And so this particular piece of work that I'm going to be speaking to you about today is focused on the survivorship care, the survivorship box on the screen. And so the definition of cancer survivorship is the period of well follow-up care and rehabilitation following cancer treatment. It addresses a comprehensive range of survivorship issues and is for the duration of the survivor's life. So just a little bit of background for everybody, because I live and breathe cancer statistics and live in the cancer world, but I know all of you out there don't. So just a little, I'm going to take us through a couple of data slides just to set the context. So cancer in Canada is a growing problem. Obviously, we're not alone in Alberta in terms of really having some capacity issues, but these statistics came from the Stats Canada 2014 edition. And it's estimated that in 2014, there was just over 190,000 Canadians that were diagnosed in that year. 2 in 5 Canadians will develop cancer in their lifetime, and 1 in 4 Canadians will die of cancer. And that translates into about 76,000 Canadians died of cancer in the year 2014. And the likelihood of surviving cancer for at least 5 years after a diagnosis, doesn't matter which disease you're diagnosed with, is about 63%. And that number has actually increased significantly over the last decade, over 10 percentage points. And that leads us to the last green bubble at the top of the screen, which is the estimate that there is over 800,000 Canadians alive at the beginning of 2009 that had been diagnosed with cancer in the previous 10 years. And so this is the number that continues to grow as we get better at diagnosing cancer early and treating cancer. We're helping people live longer, which is part of the challenge that is coming at us in terms of capacity. So what's going on in terms, I'm sure all of you have heard that cancer incidence rates, the incidence of cancer in Alberta is increasing. So this is a slide, some statistics that came out of our Alberta Cancer Plan document in 2013. And it just shows you where the projections of numbers are going. So in this slide, it's 2010, they were saying we would have about 16,000 new diagnoses that year in Alberta, and the projections are that by 2030 we'll have 27,000 new cases diagnosed in that year. And on the side you can see that what is the reason that is driving this increase in incidence. We have our aging population, population growth in Alberta, and actually the rate of change of the incidence, the actual age standardized incidence of cancer is not increasing right now. So the rise in incidence is really related to aging and population growth. And importantly, what we know about this data and these numbers is that the healthcare system, the cancer system in per se, is not going to have almost double the capacity, physical capacity, built or available to us by 2030. That's only 13 years away, and we already know that we are very, very full in our capacity to treat cancer patients. And so these are numbers that are really getting our attention in terms of our need to really understand how do we meet the care needs of this population. When we look at survivorship in particular, one of the things that's really important to understand is that depending on which cancer people are diagnosed with, their likelihood of surviving 5 or 10 years out is very different. So this screen shows you the 10-year relative survival rate for the 4 top cancers in Alberta. So we have prostate cancer at the top that says 93% of patients who are diagnosed in the last 10 years will be alive with prostate cancer 10 years out from their diagnosis. Breast is 82%, colorectal is at 61%, and at the bottom we have lung cancer at 13%. So these are important because as the previous slide showed us, the incident rate is going up. This slide starts to paint the picture that prevalence is also going up. So how long people survive and stay in the system. So here is another slide that speaks to the prevalence rates. So when we do a cross-section of all cancer patients who are alive 10 years after their diagnosis, this would be the distribution, the likelihood, the distribution in the population of people who are 10 years out from their diagnosis and still alive. So you see again, prostate and breast and colorectal are the largest groups of cancer survivors. When we look at this by tumor groups, by the type of cancer, you can see how this number of the prevalence data is really going to start to combine to have a lot of challenges for us. So for instance, on the left-hand side of your screen, you see the prostate numbers, which is the largest population of survivors. The gray box at the bottom is the people who have been diagnosed 0 to 2 years. So we have 26% of the total population of prostate survivors in Canada, which is 176,000 people. So 26% of those people have been diagnosed in the last 2 years. 33% of those people are alive and diagnosed 2 to 5 years. And then that orange box at the top are people that are 5 to 10 years out from their diagnosis at 71,000. And you can see on the screen breast, colorectal, and lung, and the distribution of that. So the importance of these slides is that to be included as in these statistics, it doesn't mean you're off treatment. It means that you're alive. And so many of these patients may still be receiving some type of treatment or hormonal therapies or long-term control maintenance. So as I mentioned earlier, 63% of, it doesn't matter which type of cancer people are diagnosed with, if we put all of the cancer diagnoses and types into the same bucket, we have a 63% rate of relative survival. However, if we actually if a patient survives 1 year with cancer, if we take that first 1 year out and then look at the relative survival ratio, it actually increases to 81%. So if we can get patients through that first year after their diagnosis, their survival, the likelihood that they will survive at least 5 years goes up to 81%, which is an incredible progress from where we were 10 or 20 years ago. So what is the impact of all these statistics on our healthcare system? So I spoke about increasing incidence, so that we need capacity in the cancer system to get new patients in for consult and treatment quickly. We are the place in the healthcare system when someone has a cancer diagnosis where the expertise exists. Secondly, increasing survival rates mean that we have growing populations requiring ongoing screening for reoccurrence, second primary cancers, and late and long-term effects. So those patients who have survived, that population is compounding and growing very quickly. And that obviously leads to growing prevalence of cancer in our populations, in our general population. There's just more visible cancer. People are living longer, and there are more needs that the healthcare system is being challenged to meet. So I love this slide because this is kind of how Cancer Care Alberta feels. We feel very crowded. We have capacity issues because, as I showed you, the incidence rate continues to go forward, and those numbers are relentless. Every year, another 16 or 17,000 Albertans are diagnosed, and if we are treating patients for 5 or 6 years, the numbers in terms of our capacity to meet their needs and to get new patients into the system is becoming compromised. And so this project that I'm going to speak about has really been driven out of the reality in CCA that we have some serious capacity issues. We also know that in primary care, you are a generalist. You look after lots of things, and cancer is but one of the issues that arrive in your primary care clinics every single day. So we have these two different systems that are trying to collaborate. We have the generalist system in primary care, where cancer is one thing, and then we have this highly specialized system in the cancer system where we have different organizations around the type of cancer our expertise is in. So breast cancer has a particular stream of expertise, and colorectal cancer and prostate and lung, and all of these different specialist services are trying to get your attention and help and send you information about what they want you to do with these cancer patients. And so this makes this relationship very complicated. So what are the common survivorship issues that arise in primary care? And this is information that I've pulled from the education module that I'll refer you to at the end. Number one, we know that when a patient has a history of cancer, it may actually divert medical attention from other health issues unrelated to cancer. So it's like it trumps everything, and other issues like their diabetes or their chronic heart disease sometimes take a back seat when they actually maybe shouldn't be. Number two, most cancer survivors are over 65 years old and typically have multiple comorbidities. So cancer is often not the only thing these patients are challenged with, and so that juggling of comorbidities and different specialty services is a very complicated piece for primary care. We know survivors face a spectrum of health concerns that are different than those faced prior to diagnosis, and that can significantly impact the quality of their life. And often they're unfamiliar with how to cope with those things because they've never had those problems before they had cancer. We know that survivors are at an increased risk for secondary cancers related to either the treatments that we've given them or related to the simple reality that if you have one cancer, you are at an increased risk of developing a second. And we also know that the specialized knowledge base in cancer care is evolving quickly. We in cancer care in our specialized services have trouble keeping up with the pace of the knowledge explosion that's happening around how to treat cancer. And so all of these things must also be impacting on how primary care can keep up with this knowledge base. So we also know patients' realities in this experience is that patients often feel that they are the ones that have to connect the two systems, primary care and cancer care, and are often not sure which system to turn to for what issue. Cancer survivors face short and long-term consequences as a result of having been treated for cancer and often require rehabilitation, supportive care services. And really, from a patient perspective, we have heard that nothing prepares the patient or family for the anxiety that follows the completion of acute therapy. So I'm going to just take us out of this presentation, and I'm going to pull up this patient voice, the video from this patient advisor. So just give me a second here. All right, hopefully we'll just put this on the big screen. All right, it's only a couple minutes long.
Moving into survivorship can be a challenge as we go from the constant care and connection with our healthcare team to a more occasional care. I know when I was going through treatment, I felt like I had really good access to the doctors and the nurses and the other healthcare providers that were there for that time. But when treatment ended, I felt kind of dropped. It's important for me to know that my doctor can communicate with me and talk with me about things like my fear of recurrence or an actual possible recurrence, or to deal with the ongoing side effects and things that come up as a result of having gone through.
Sorry that video is not working. We're just going to try again. The sound was not. I tried to turn it up on the computer. Oh, no there. Worries. That worked. That's better. It was at 6:10, I think. Close enough.
Care has been the least consistent and most variable phase of the patient experience, in contrast to the careful structure of active treatment.
Moving into survivorship can be a challenge as we go from the constant care and connection with our healthcare team to a more occasional care. I know when I was going through treatment, I felt like I had really good access to the doctors and the nurses and the other healthcare providers that were there for that time. But when treatment ended, I felt kind of dropped by the system. It's important for me to know that my doctor is going to communicate with me and talk with me about things like my fear of recurrence or an actual possible recurrence, or to deal with the ongoing issues and side effects and things that come up as a result of having gone through the treatment. I do realize my doctor can't know everything, so it's important for me to know that they are connected with other healthcare providers and willing to do a little investigation and learn about things in order to help me feel like I'm getting the best care possible and not falling between the cracks.
So I just wanted to have that voice in there because there's nobody that says it better than our patients. And what that patient shared about feeling dropped by the system when cancer treatment ends is something we hear a lot from patients after their close connection with us through the treatment phase is done, and then they are not able to see us as often, and they do feel a bit lost. So we also know there's a variability across survivorship care and how it's delivered in our province. And that relates to a lot of different details. Number one, the consequences of cancer and its therapies have been poorly understood because not as many people survived this long. And so it really is an evolving area of knowledge. As the population of cancer survivors has grown, our awareness of their care needs has also grown. We know that medical school curricula and residency training programs have emphasized details around screening, diagnosis, and treatment of cancer without a focus on late and long-term effects of cancer on survivors, simply because the knowledge base wasn't there. Little research has been done into effective models of survivorship care, and there are few systematic implemented programs. And number four, ineffective communication mechanisms exist between the cancer system and primary care system. So those are all reasons that we know are at play for the complexity that faces us as we try to think, how do we collaborate better in this phase? So I love this slide because it really does feel in some ways around passing the baton and really understanding, okay, so when do we hand the baton? How do you know that you're going to get the baton? I'm not going to throw the baton at you. We want to make sure it's a nice handoff, that people are comfortable holding the baton and all of that. And so really we're going to be talking about the project and the things we're doing here in Alberta to try and make the handoff of patient care after treatment more smooth. So we set off with funding from the Alberta Cancer Foundation and from the Alberta Cancer Legacy Prevention Fund to understand how to improve our transitions post-treatment in Alberta. And we used a very simple 3-step process for this work. We began with understanding and engaging and understanding the issues and who are our stakeholders and a variety of different engagement activities. We then took all the knowledge that we've gathered, and we're going to talk about that in a second, into a design and develop phase where we have put the best minds that we had available to us together to come up with some strategies that could help us in terms of knowledge translation between the cancer system and patients and primary care. And we're just moving into the implementation phase where you're going to start seeing different letters and information coming from cancer care services in the short future. So just to step us through the process that we've gone through, we definitely went to the literature and to published research to understand what is the best evidence around supporting patients in the post-treatment phase and the best evidence around primary care integration in terms of cancer services and survivorship. We also looked across Canada. In cancer care, we're very lucky to have a really robust network across the cancer agencies in Canada, and we collaborate quite closely. So we're not all trying to recreate the same wheel. We're trying to share knowledge and share best evidence and our practices so that we can leverage things forward. And so particularly to this work, Cancer Care Manitoba, Cancer Care Ontario, and Cancer Care Nova Scotia were much further ahead than we were in terms of primary care integration. So we've learned a lot from them and adopted parts of their models. And then here in Alberta, we've been working with our Alberta Health Services partners. So in terms of primary care integration network, we've been working with chronic disease management, as well as then with primary care networks and our cancer control staff and patients and families. So here's the list of the different groups we've really come to understand as our key stakeholders. So obviously primary care is a key stakeholder in this work. We were lucky enough to get funding to go out and meet with several primary care networks and clinical care teams. So Dr. Churcher was involved in one through the Mosaic PCN here in Calgary. The Big Country PCN in Central Zone was one of our PCNs that we worked with. Specifically, the Heartland Clinic in Stettler was our access to clinicians. We worked with the Southside PCN in Edmonton, and I think it was St. Thomas Health Clinic there, and we worked in the McLeod River PCN in the North Zone, and that was primarily with the Whitecourt Associate Clinic. And we also had 2 Métis settlements that participated in our primary care engagement. And in cancer control, we've been working with 4 different tumor groups to begin with. So breast, GU, GI, we're not done GI yet, but we're working with them, and gynecology, sorry, I was drawing a blank, and also working with teams such as Xanthula's team with the Guideline Utilization Resource Unit, our ARIA team, so our EMR team, and the list goes on and on. And then patients and families. When we went out and worked with the primary care sites, we had each site help us identify patients from their community who have been through this process of having cancer treatment. And we actually engaged with those patients and talked to them about what this has been like for them being through treatment and what could have maybe helped their transition better. And so what did we learn? And obviously I'm going to give you the high level Coles notes because we learned a lot of things. But what we really learned was that this work is really going to need to be facilitated through great teamwork and collaboration with all of the different service providers and groups involved. And so I love this slide because sometimes it does feel like we are on our own little piece of the puzzle, not connected to anyone else's. But you can see we're reaching out and trying to pull those pieces together. So really all of the key stakeholders, so primary care providers that we engaged with, cancer control providers, and patients and families, they all agreed that the issue of supporting people at times of transition post-treatment was very important. But it was very interesting to understand that each group had a different motivator. So what got their attention or what made them feel like they wanted to be part of this work was very different. So from Cancer Control Alberta, no surprise, our motivator was capacity. We have no capacity, and if I have to make space for new patients coming in the front door, we need to figure out a way to transition patients in the follow-up phase back to primary care, because I just can't continue to do everything because these new patients just keep rolling in the front door. When we talked to primary care, they agreed. They said, absolutely, we need more information at point of transition when cancer control is no longer going to do follow-up and that patient's going to be followed up in primary care. But they said that importantly, another key important time point in the patient journey that primary care providers said was at the end of treatment. So that regardless of who's doing the follow-up care, so if it's going to come straight back to primary care, absolutely they need information. But if cancer control is doing the surveillance for the cancer that has been treated, there was a sense from primary care providers that there wasn't enough information at the end of treatment, because that's where the patient's relationship, frequency of visits to the cancer system declines, and it's more likely that cancer patient's going to end up in the primary care office asking questions. And if cancer control hasn't really done a good job in communicating exactly what that follow-up care is going to look like and who's doing what, it can cause some gaps in knowledge, and then the patient again feels like they're bringing knowledge to the primary care physician when there isn't that solid knowledge that has come from the cancer system. And when we talked with the patients, they actually agreed with both of the points from primary care. So yes, definitely end of treatment was a huge gap for them in terms of knowing how to manage the post-treatment phase, regardless of who is doing follow-up, as well as that point at which they're discharged from follow-up in cancer control. But the patients actually said, help us earlier, help us be prepared for transitioning at the end of treatment or the changes that come with the end of treatment. Even if cancer care is still doing that follow-up, help us to be prepared for it, because you can't just drop it on us. Oh, you're done treatment now, things are going to be different. Like, help us understand that. So the patients were asking for a little bit earlier conversations about this. So we took that and we then kind of went into learning about all of the other pieces of feedback that we got from the systems. And really the big learnings from cancer control was that in order to improve how we communicate with primary care and how we transition patients, we have to have provincial consensus on follow-up recommendations. So in our own house, we had a lot of different practices. And I actually had a doctor from Stettler who told me about an example where he had a colorectal patient that had been treated at Edmonton at the CCI, colorectal patient had been treated in Red Deer, colorectal patient had been treated in Calgary at the Tom Baker, all the same stage, 3 different sets of recommendations in terms of follow-up to who to do what. And so he showed me this case, these 3 cases, and said, like, this is confusing. You guys are the specialists, and yet from the same group, I'm getting 3 different sets of recommendations. So I've been able to take those voices back to our teams and say, we need consistent follow-up recommendations. These follow-up guidelines or recommendations need to be written for the end users. And so this is a big change for us too, because usually our guidelines are treatment guidelines, and we are, the cancer care team, are the end users. So they're developing the guidelines and they're using the guidelines. But when we talk about follow-up guidelines, the end users are not us. They're primary care and their patients and families, and to some degree us as well. But we needed to be more aware of how other teams wanted to receive the information, because we weren't the only ones using these guidelines. And the third piece from cancer control was this idea of consistent communication so that we meet the end users' needs. And these communication methods must be simple and easy to use in our clinical environments. From our patients, we heard that patients need more information about follow-up care requirements to really be partners in the post-treatment follow-up care phase. And the patient role in these 2 systems is very different. So this was another important learning, in that in cancer control, we drive appointments to our patients. We tell them when their next appointment is. We tell them when their CT scan is. We tell them all of the pieces and give them the schedule. Whereas primary care often has a more passive relationship with the patient in terms of those follow-up appointments. The patient needs to phone in and make the appointment. There are some primary care networks where they get reminded, but not all. And so being clear with the patient that these 2 systems expect different things from them was an important learning from the patients. And that patients also said, we don't know what we need to know before it happens. So how do we figure that out once we're on the other side of this close relationship through the treatment phase? We don't even know what's going to happen in the next phase. And so can you help us be prepared with more relevant information in our hands as this goes forward? What we heard at a high level from primary care is consistent content areas regardless of cancer type. So again, going back to that idea of generalist system, primary care being generalist, and we're sending information from our specialty streams, we weren't paying attention to how we were messaging information across our specialty streams. So each tumor group was designing their own way to communicate with primary care, and all those different ways of communicating was ending up on one desk, and that's confusing. So really the message from primary care is, we understand that there's lots of different content in each type of cancer that we need to understand, but communicate with the same way, same content areas, same texture, so we can start to trust that you're always going to send us the information the way we need to see it. Primary care also asked for us to include recommended follow-up practices, late and long-term effects, and signs of reoccurrence, and other supports available and other screening recommendations. Those were the key areas that primary care said in our communication. That's what we want to see consistently. And the third piece was that primary care said we need an easy route to ask questions from the specialists in cancer, and or to return our patient to you if a recurrence is identified. So those were the big messages that we heard from primary care. So now I'm going to show you the model that we came up with and what we are working to implement across all of our tumor teams, specifically remembering that our focus right now is on populations of patients who are likely to have long periods of wellness after their treatment. So we're really focusing on the early stage cancer in breast, prostate, gynecology, cervical, endometrial, and testicular cancers. Those are the ones we're starting with because we needed to start somewhere. Can't eat the whole elephant in one sitting. So those were the groups of populations that we thought we could do this. And then the question was, could we figure out something that's common in terms of our process that can go across tumor groups? So the contents is different, but the process would be the same. So for each of those populations I was talking about, we started obviously with the development of a guideline. So can we get provincial consensus around what our recommendations for follow-up are? The second piece that we've built is a transition class. So this is the piece where we start to talk to patients earlier on in their journey to say, you're getting close to the end of your treatment. At the end of your treatment, you're going to be in a different phase of your cancer journey, and you need to understand what your role in that post-treatment phase is. So this class is not about different types of cancer. It's really focusing on the patient role in the post-treatment phase, looking at your care team is primary care and cancer care, and and that we're working together to meet your needs. So at the end, when a patient is finishing their curative intent treatment, the oncologist is going to be flagged to make a decision. Is this patient going to receive follow-up care in cancer control for their surveillance for the cancer we've treated, or is this patient eligible to be transitioned directly back to primary care? So this is the first decision point. Based on that, if either route, the patient is going to receive a self-management resource which is linked and tumor group specific. So for a breast patient, they will get a breast self-management handbook. And again, this is something put in their hands at the end of treatment before they start to have the issues that happen in the survivorship phase. And it's really developed around commonly asked questions from people with your kind of cancer. And it also has general issues that all cancer survivors have. So it's a fairly thick book. The intent is not for the patient to sit down and have to read it all that day that we give it to them, but it's a resource that they can go to and find more information for things like genetic counseling, lymphedema, sexuality issues, nutrition, exercise, and those kinds of things. So if the oncology team decides that this patient's follow-up care is complex and they need to do surveillance, the patient will go in this top stream, which is called shared care. And I know we are always sharing care with you. I completely understand that concept, but for our cancer care team, we're trying to draw their attention to the fact that even if we're doing their follow-up for their cancer that we've treated, this patient is continuing to see their family physician for other elements of their care. So at this point, we are going to be generating some templated letters based on the type of cancer the patient's been treated for. And there's two versions of those letters. There's one for the patient and one for primary care. They deliver the same knowledge, basically outlining that CCA will be doing the surveillance. Your patient's finished their treatment. Cancer Control Alberta will do the surveillance. This is what the surveillance is we're going to do based on the guideline. These are the things you need to watch for in terms of signs and symptoms of reoccurrence, late and long-term effects, and other resources that patients may find helpful in their wellness. After a period of time when we're doing that follow-up care, there will come a point when the oncologist decides that this patient no longer needs to be followed up in terms of the cancer specialist follow-up. At that point, we would actually discharge them from our system with the NFR, which is our signal in our EMR. And at that point, it would trigger the delivery of another set of letters, one to the patient, one to the primary care provider, exactly similar to the end of treatment letter, but this one says your patient is finished follow-up with the cancer system. They are in year 2 of 5 of recommended follow-up. Here is the things you need to book, and then it also has late and long-term side effects and those other topics. So there is some repetitiveness between the two letters, but it is our effort to try and consistently get you the information at the right time point to answer the questions. The other stream at the bottom of the slide you see is if this patient is actually not going to receive any of their surveillance follow-up care in cancer control. So at that point, the patient would be NFR'd right there, and they would receive the transfer of care letters the same way, so primary care and the patient. These letters are the same letters as would be delivered at the end of the shared care route, but they would say your patient is in year 1 of 5 of recommended follow-up. And so that is the only difference between the letters, and that patient would never see an end of treatment letter because we're not doing, their end of treatment goes right into the transfer of care. And the final piece that is part of our model is the development and the delivery of a Living Your Best Life workshop. We offer this workshop every 6 to 18 months, 6 to 12 months, sorry. It's designed to support patients who they hit a wall around 6 to 18 months where it's like the return to normal isn't as easy as they thought it was going to be, and often they need a deeper dive into stress management, lifestyle modifications. And so this workshop is really intended to support them at that point of being ready for more information around how to live the best life they can after treatment. And so the other piece of this model that we haven't yet developed is the rapid reentry route. And that is, there's lots of conversations going on in cancer control right now about the fact that the idea that maybe we don't discharge patients. So I know on here I'm talking about discharge. Maybe we just don't book any appointments, and that the patient stays in the system, and that if something goes wrong, there is a quick and rapid re-entry into the system, into the same clinic that treated their cancer in the first place, and we just pick up from there. And so we're trying to figure out how to simplify that process. It's proving to be quite complicated, but we're definitely working on that. That's the one piece that's still outstanding. So the beauty of this model is that it's flexible enough because we do have some different practices in cancer control in terms of, for instance, the colorectal group in Calgary discharges patients right after treatment back to primary care for follow-up, whereas the colorectal group at the CCI in Edmonton has a virtual follow-up clinic for 3 years where they do the PSA they do the CEA and the other testings and follow those patients for 3 years, and then they transfer care back after 3 years. So we actually needed to be able to manage the complexity that our systems are set up differently, but still communicate consistently and have consistent follow-up. So whether that patient's getting their follow-up in the virtual clinic or in the family doctor's office, the recommended timelines of what screening should happen and how often is the same. So this is just a quick overview of the different groups that we've been working with. So as I said, the first 5 on that screen are the ones that are really the closest to go in terms of implementation. So I would say in the next month, you're going to start seeing new letters arriving in your office for patients that you've been caring for, if they are one of those first 5 populations. We're working with Hodgkin's lymphoma and B-cell lymphoma in the hematology group, and then colorectal cancer is still in development. But I would say probably in the next 6 months, those 3 packages of resources will be done. And so it's got the guideline, the end of treatment letters, the transfer care letters, and that guideline-linked self-management resource for patients. So they've really done a lot of work around the creation of these packages, and the real proof in the pudding will be in how we are able to implement and get these flowing to primary care providers and getting some feedback from primary care whether this is helpful. So this is we do have one published article about the breast cancer letter. So this is, I pulled this out of the article that was published in Current Oncology. But basically, this is an outline of the patient transfer letter. I mean, there's obviously more. This is just the highlight. Congratulations, you finished your treatment. And then the other elements that are in there around follow-up, endocrine therapy, and support and resources. This is the same version, the physician version of that same letter, so the wording is different, but basically holds the same content as the patient letter. So really trying to get the patient and your primary care provider on the same page. So finally, I'm going to just reference the e-module learning that I pulled that little video clip from that I mentioned earlier. It's called Moving Forward After Cancer, and this is the e-learning suite for family medicine and oncology post-training. And I'm going to actually just pop out of here and show you the website so that you can see this. This is on the University of Manitoba. It's completely free. You just have to set up an account when you go to register. You set up an account and you get logged in, and it has these different lessons that are all self-contained. So survivorship phase of cancer, which is a lot of the information I talked about today, is presented in different ways in that module. Unit 2 is around a coordinated shared care model for follow-up care, surveillance and interventions for cancer-related fatigue, surveillance interventions for anxiety and depression, follow-up care for all cancer survivors, and then they have some specifics around breast, prostate, and the course completion. So our model may not look exactly like the model that would be shared in this video series, because obviously we've kind of adapted it for the Alberta context, but the content and the issues and the ideas that they share in this video are really well developed and have been developed by a consortium across Canada, so very evidence-based. And that brings me to the end of my discussions today. So if anybody has questions or comments or thoughts, now is the time to share them.
Thank you, Linda. That's great. I would encourage people to, I have my chat room open here, so I'd encourage you, if you have questions, to type them in, and then I'll pass them on to Linda so that she can address them. Having been involved myself in some of this work, it's just amazing to see it moving along. And I think we're at a great time in Alberta. There's a real camaraderie and working together between Alberta Health Services, not only in cancer care, but in other things as well. So this is really amazing that we're seeing this in this area. I think cancer care is actually further ahead at trying to bring things together, but yeah, it certainly is a challenge. And with all the other issues, certainly patients, when they get involved in cancer, they forget about their diabetes and things can go sideways. Mm-hmm. And then the other issue is at the end of care, where they're relying on their cancer specialists and feel more comfortable. So I really am glad that you have this transitions class. And certainly in my office as well, we do have diary cards. We have a system of knowing what people need. So these letters you send out, we leave them on our paper file just for reference, but we actually write everything down and it goes into a diary card system. So we can do that through EMRs as well. Yeah, so I think we have a thank you very much from Natasha Connell. She's busy typing. Maybe she has a question too.
Yeah. One of the things that while I'm waiting for that question, one of the things that we did hear from primary care is, there was a sense that cancer care is ahead of other specialty service programs. And it's like, well, you guys are the ones that do things better than some of the others. So that was nice to hear, because I sometimes don't feel that way when I'm in the system. I get frustrated. But there has been a lot of interest that this model could work for other specialty services as well. So I think some of the PCNs have been quite interested in how they could leverage that forward. Mm-hmm. And from primary care, there was also a sense that the well patients are maybe not the most intense need area for primary care to have more knowledge, and there was a real request for more information about patients that we're not going to cure, and improving our collaboration and support in those patients that are on treatment for a very, very long time. So definitely we know that, and that will be our next chapter in work, because this isn't just about well patients, it's also about those other patients that we share along their journey.
Great. I'm getting some other thank yous as well here. Natasha is still typing away, but she says, just wondering, it says 2 files for download, but it was only 1 file that she could see, so she was wondering if there were 2.
On the presentation?
Yeah, I'm not sure. I know there's supposed to be at the end, there's the evaluation and the attendance records, but
Yeah, so I'll make sure that the web or the presentation is available to anybody that wants it, and all of the web content or the web links are embedded in the presentation. So hopefully you can find everything you need.
And Dana's written as just the one file, so that's
Okay. Okay.
Yeah. It looks like we have a question from Stephanie Kerwin coming up here, or maybe another thank you. There's lots of thank yous here. I think people are probably just busy processing a lot of this material because some of it may be new.
Yeah.
I mean, it's not new to me, but even I was writing notes down, so there was highlights of things that are upcoming. So
Yeah.
that's
No
really
worries.
very good. Yeah, multiple people are typing at the moment.
Good. Good. Good.
Yeah.
One of the things we heard from our primary care teams as well was that there is a need for more education around cancer knowledge, the general knowledge for primary care, because so many patients are living so much longer that there are long-term implications that we've always thought that cancer was something special and the cancer system was going to manage all of those needs, and that just isn't the way it is playing out anymore. So definitely is on our radar that we would like to do more collaborative education experiences as well.
So Stephanie Kerman wrote, can we access the MD follow-up letter to primary care without it being for a specific patient?
Yes, they can. So on the Guru Guideline website, which is on our the external AHS website, just type in cancer guidelines, and on the cancer guidelines, depending on which, they're all sorted by the different kinds of cancer. So breast, eye, you just click on it and then you scroll down. It has that's where you would look to find all of the recommendations for screening and getting people worked up for their coming to us. So if you just continue down the list in that tumor group, you'll find the sample letters there. So if you don't get a letter, you can go to there, and they're all updated. We'll be updating them with our provincial consensus very, very soon. So within the next couple of weeks, all of the ones that I talked about, even if you don't get it in the mail, is going to be up on that external website.
Great.
As well as the patient version. So not only will the physician-led version of end of treatment and transfer of care be there, but also the patient version, so you could print them off and give them to your patient as well.
That's excellent. I see that we have the information now on your screens as far as the evaluation, which is sent through SurveyMonkey, so nice and straightforward and easy to do. And a little bit of an advertisement for continuing medical education programs here to the Cumming Centre at University of Calgary. And also posted about cancer guidelines and to the Alberta Health Services site. So that's right there too. You can bookmark that and use it and just go to what Linda's presented. So yeah, the people at Guru will be very happy if you do that. It will mean that all their hard work has not been in vain.
That's right.
Yeah, we're getting lots more thank yous here. A few people still typing.
Yeah. No worries. I don't know what we would do if we didn't know how to type.
That's right.
In this day and age.
Val Nigwin, I have a patient whom I only know for the past 5 years, and she had bilateral breast cancer in 1997, 1998, so a history before, apparently cured. She got recurrent cancer with metastases 2 years ago. When I sent her back to the Tom Baker, I was asked to send her previous record, which I don't have. She was treated at the Tom Baker. Does the Tom Baker keep records that long?
Yeah. Our EMR so there may be pieces that were ordered or tests that were ordered in primary care that should be in net care that we would access, but our cancer EMR goes back as long as the cancer EMR has been, which is longer than 97. So they would still have the file from whatever treatment that we gave in 97 if it was done in the cancer system. And the paper chart is there as well. So the only challenge in our world in terms of cancer services is that the surgical interventions are usually done in the zone in the hospitals, and our EMR, so when I say our, I mean the Cancer Control Alberta EMR, is usually only the ambulatory care. So sometimes there's a bit of a disconnect between different charts, whether you're in inpatient or whether in ambulatory care. But either way, we'd be able to find the information.
I guess maybe part of the question was if that information is already at your site, why are you asking the
Oh,
information for it? So I'm
yeah.
just, you know, it's just something we get all
Yeah.
the time. It's the same with MRIs and CTs, that information is already in the system and they're asking for copies. So
Yeah.
we just kind of ignore, but
Yeah,
yeah,
it's
so maybe that's just something to find.
absolutely. And I think that there's a lot of different people involved in this, in the work of getting a patient back into the system. So it could be a clerical person, it could be this or that. So really, we shouldn't be asking you to send us information. We should know how to find it, but it's not a perfect system.
Yeah.
Yeah.
No, that's okay. Lots of thank yous. Great
Oh,
work.
good.
More thank yous. Thank you to me for clarifying that. So I got to thank you. That's great. Are there any more questions for anyone? I know we're coming to near the end of the session, and we've had a few good questions there. I know, as I said earlier, it's a lot of material to get your headspace around. So I hope we've left you with something to digest and to take to your patients. I think the transitions group and working on all of my second job besides being a family doc is I review disability files for Manulife and Sun Life. And we end up with a lot of these patients with fatigue and things. And it's lovely to know that there are some resources that are becoming available, at least in Alberta, for helping those patients move ahead past that 6-month time when they sort of get stuck.
Yeah.
And we don't really know what to do in family medicine. We want to be supportive of it in the right way. So I think these are really great initiatives.
So I'll put a plug in while we still have everybody on the line that we just created a new self-management resource for fatigue. So cancer-related fatigue is the #1 symptom while on treatment and in the post-treatment phase. It's on My Health Alberta, and it's a whole video series where we have patient stories and healthcare practitioners broken into separate little modules that a patient can just go and watch the module that's most important to them. And there's a booklet that goes along with it around managing cancer-related fatigue, and it's really great. It's just gone up in the last couple of weeks, so brand new resource. So have a look. It's also linked through the Primary Care Resource Center. So for any of you that have been on the Primary Care Healthcare Resource Center lately, which used to be chronic disease management, there's now a tab that says cancer. For the first time, we've now got cancer on the Primary Healthcare Resource Team page, and in that there is some resources for survivors and specifically also around fatigue management. So have a look, because there's some really good stuff there that you could refer your patients to.
That's great, Linda.
Yeah, awesome.